Good afternoon. Thank you so much for the opportunity to share today on the 2020 view of the new frontiers in the management of ovarian cancer. I have no conflicts of interest to disclose. Before we get started, I kind of want to give you a snapshot out of where we are with ovarian cancer. This is the 2020 data for the 5-year survival, which for overall is 47.6% for all patients. But when you start to look at the breakdown of how we got to 47%, you can see it varies from the early stage 1, where we have a very high 5-year survival of over 90%, down to advanced stage or unknown stage of 25%. And so when you average those together, you can see we come to 47.6%. But you can see majority of patients are diagnosed in these later stages. So it can be a little misleading of how well we're doing with ovarian cancer. Ovarian cancer does tend to be a cancer of older women with a median age, a mean age of 63 years at the time of diagnosis and 70 years.
Mind, please open your cam.
Pardon me?
Yeah, I'm talking to you. Can you open your cam, please?
There we go. Sorry. I don't need to see this. Okay. Okay. There we go. Okay, sorry about that. So ovarian cancer has been known as the highest mortality among all female cancers. And this kind of gives you a snapshot of where breast cancer is by far the most common cancer among women. The mortality rate, we've done great over the past few decades with a mortality rate now of only about 15.3%. We do fairly well with uterine cancer, which is the most common gynecologic cancer. Cervix cancer is less frequent here in the United States, but worldwide is still one of the leading gynecologic malignancies. But we still do better than we do with ovarian cancer. Ovarian cancer, despite decades of research, we're still have over 64% rate of mortality, and that's in 2020. So, you know, over the past 7 decades, and majority of my career that started in the 1990s, you can see by this graph, which is the number of patients over each decade, years of basically capturing the last 20 or 16 years of data. These lines are almost parallel. The blue line represents the number of newly diagnosed cases, and the green line is the mortality. So we're not making a overwhelming advancement, you know, seeing a decline in either one, the number of cases, or at least in the mortality. And I highlight here some of the milestones we've reached. In the 1990s, the big breakthrough was the approval of the taxanes. And that's where, you know, about 10 years later, we did see a little bit of a drop in the number of cases and mortality. 2006 was where we're talking about today, was supposed to be a game changer with the landmark study by Armstrong and colleagues that showed that IP therapy had slowed down practice and some additional clinical follow-up really changed its place. We've experienced drug shortages worldwide, still are today. You know, they really peaked in 2012, but they're still present today. And then in the past 5 or 6 years, we had the introduction of Bevacizumab, which is one of the few targeted agents. Cancer as well, the introduction of the first PARP, and these both in a recurrent setting. In 2018, they moved up to first-line maintenance, and just this past spring, niraparib was the second PARP inhibitor approved for first-line maintenance therapy. So let's talk about what happened to IP chemotherapy. All we're touting in the media, as well as many medical and gynecologic oncology meetings, that this was going to be the next cure and significant impact on improvement in survival, which you know, you saw in the graph did not translate in the past decade. So, you know, the rationale was primarily that ovarian cancer is a disease of the intraperitoneal cavity, and that the IP chemotherapy would treat both locally as well as systemic disease. The assumption was that there was a uniform distribution that's achieved with dose intensification, and that there may be less systemic toxicity. So there were a number of studies leading up to GOG 172, the study by Armstrong in 2006, that did show an improvement in overall survival when looking at the IV versus IP therapy, and that was encouraging. And this last trial here was the one that really hit the media, you know, was a game changer. Everyone thought this was a new approach, but as you can see, we had been looking at this for quite some time. Following up study by Armstrong and colleagues was GOG 152, because in gynecologic oncology, majority of clinicians prefer carboplatin over cisplatin due to the toxicity profile. And decades before, in our primary standard of care, carboplatin replaced cisplatin in the combination with taxanes. So this study was a follow-up to not only look at IV versus IP, but also look at the role of bevacizumab and bevacizumab maintenance in improvement of overall survival. And you can see arm 1 looked at our weekly paclitaxel plus carboplatin plus bevacizumab, followed by bevacizumab maintenance. And arm 2 looked at the paclitaxel IV, but the carboplatin IP plus bevacizumab. And then arm 3 looked at the standard arm of the initial study by Armstrong and colleagues that looked at the paclitaxel IV plus cisplatin IP, and then paclitaxel on day 8 plus bevacizumab, and looked at primary progression-free survival as well as toxicity. And overall, this study concluded in March 2016 at the Society of Gynecologic Oncology meeting, reported they found no difference between all 3 arms, or a difference in toxicity was actually a little bit higher those arms that received IP therapy. So we concluded from this that the addition of bevacizumab and bevacizumab maintenance was just as beneficial as IP chemotherapy in the clinical setting, which the reasons why this is important is kind of to think of the struggles of giving IP therapy. This additional study was also looking at the same regimen plus or minus the addition of bevacizumab, and the study was completed in November and hasn't been reported out since the Society of Gynecologic Oncology didn't meet last March because of COVID-19. I'm sure we'll get an update on this soon. But IP therapy itself can be a challenge. The IP catheter does need to be typically placed at the time of surgery, so you don't require the patient to have another procedure. The IP therapy given by the way Armstrong and colleagues does require a 2-day treatment. Removing that IP catheter, it's another source of infection. The concept of trying to keep your normal saline in some of our smaller women to administer this much fluid into the cavity is challenging, especially in some smaller women. I know we struggled with it in practice. And it does require one learning and a little bit more time intensive, and patient selection is really key important. So that's why there was some slow adoption into practice, because the patients don't tend to tolerate the IP therapy pain, the struggles with pre and post hydration fluid, the more time, intensity, and ability to get enough nursing available to do it. And there was a slow adoption into practice. With the report in 2016 that Bevacizumab, which is a 30-minute infusion, fairly well tolerated, minimal toxicity, was just as effective, really shifted that focus in practice. So when we look at the recent advancements over the past 5 years or so, this timeline kind of shows you back here in 2014 where Bev was first approved and olaparib was approved for the treatment of advanced ovarian cancer. And you can see in the last 3 to 4 years, we've had a lot of additions of the additional 2 PARP inhibitors, rucaparib and niraparib, being approved, and recurrent, moving on to olaparib then being approved for first-line maintenance, and now niraparib as well. And I'm sure rucaparib is not too far behind as that study has just concluded. So, as before we talk about the PARP inhibitors and bevacizumab in first-line maintenance, one of the big game changers, probably starting about 3 to 4 years, about 3 years ago, was the concept of genetic testing and screening as the standard of care for all newly diagnosed patients with ovarian cancer. And this has now really gotten adopted better into clinical practice, being routinely done, whether it's next generation screening, foundation testing, in vitro testing, or a combination of the above to look at both germline and somatic mutations. The one struggle that we have found is ovarian cancer tends to be one of the most highly mutated solid tumors, but the least number of actionable targets. And so that's where there's still a lot of ongoing research to look at the role of targeted therapies in the gynecologic oncology setting, trying to find that combination that really can help make a significant impact. At this time, bevacizumab and inhibitors are the 2 target agents that have come to fruition. But having this information up front, a lot of knowing their BRCA mutation is present, or they have high HDR, LOH, loss of heterozygosity, is really helpful in guiding what your primary maintenance therapy may be. So BRCA 1 and 2 genes are tumor suppressor genes. About 15% of all ovarian cancers express BRCA 1 or 2, primarily BRCA 1. And this is associated with a higher risk of people who will develop ovarian cancer over their lifetime. And what has become more prevalent focus is this loss of heterozygosity, or LOH, which may be present in the absence of a true BRCA mutation itself. And this is where we have found more benefit of the PARP inhibitors. So bevacizumab was the first to be approved, and this was in the first-line maintenance, and this is based on the ICON-7 study, which was an international study that looked at Taxol Carbo, which is our primary standard of care as a platinum regimen. This is Taxol Carbo Bev, followed by bevacizumab every 3 weeks. And you can see the bevacizumab dose has fluctuated throughout the different studies. It can be anywhere from 15 to 7.5 milligrams per kilogram. So this study looked at progression-free survival and saw an advantage at 36 months of about a month. A little over 2 months was considered statistically significant, and a little over 2 months at 42 months. And overall survival was just over almost 9 months advantage of overall survival. So this was considered clinically significant as well, and has been adopted into practice in many arenas. GOG 218 was a follow-up study to ICON's 2007 that was done here in the US by the GOG, the Gynecologic Oncology Group, now in our Oncology, that looked at the Taxol carboplatin regimen, and then this is a study, they used the higher dose of bevacizumab and looked at with or without the bevacizumab maintenance. And in this study, they also saw an improvement in the bevacizumab arm of almost 4 months. And although there was no significant difference in overall survival, this improvement in progression-free survival was encouraging. And one thing that we'll talk about, especially from a pharmacy perspective, is looking at the cost. And the cost-adjusted progression-free survival with the addition of bevacizumab is significant, and these are US dollars. I apologize, I didn't convert to all the international currencies, but the bottom line is that the incremental cost ratio, the ICER, is significantly higher than what would be deemed as cost effective. So the use of bevacizumab in first-line maintenance was debatable. The key thing to kind of keep in mind when we think about this, because we'll come back to this with the PARP inhibitors, is this cost is typically cost to the institution or the infusion center that is administering this IV medication versus outpatient prescription. So that's where the cost impact may shift, but either way, it's something to keep in mind. So what's been most exciting and probably in most of the headlines is the first line. I put in parentheses consolidation of both of these.
2 minutes.
The consolidation is important. It's rather, there's no active disease being measured in the first line arena. So I'm sure you're all familiar with the PARP inhibitors, but the key thing to keep in mind here is that it's PARP trapping as well as synthetic lethality that's associated with these. So this is a summary of all the PARP indications, and we're going to focus on these two with first-line maintenance. This first-line maintenance for the olaparib was based on the approval was based on this SOLO-1 study where they randomized patients 2-to-1 to olaparib versus placebo. And you can see that there was a 64.4% progression-free survival at 3 years in the olaparib arm versus 26% in the placebo arm, and this was statistically significant. And these patients all had the BRCA mutation, and so that was what its FDA's approval was on patients that had achieved a complete response to primary treatment and had the presence of the BRCA mutation. The PRIMA study, which recently was reported out in last September at ESMO and published later in 2019 and recently FDA approved, randomized patients to niraparib 2-to-1 versus placebo, had a dose modification in 2017 to 200 milligrams based on their weight and platelet count, and looked at a similar primary endpoint. When you looked at all patients with the homologous recombinant deficiency or some kind of mutation present, niraparib had a significant progression-free survival. What was more interesting is that this held true in all comers for the study that had partial response or in the absence of LOH or BRCA mutation. So niraparib's approval is for all ovarian cancer patients in the first-line maintenance, so a little bit of expanded indication. The role of the oncology pharmacist in PARP inhibitors is really helping in screening for potential drug-drug interactions, dose modifications based on organ function, and then monitoring weekly labs and making those dose modifications prospectively to avoid toxicity and providing supportive care. So this is kind of a highlight of the PK. The big thing I want to focus on is rucaparib is the only one with an inhibition of the CYP1A2 and 2D6 pathway. And niraparib is the only one that only has phase 2 metabolism, but that in itself may have some drug interactions. So when we just quickly, I know you're all familiar with this, when we look at inhibition, just be careful, is the patient on a substrate, and will the patient need to stop the inhibitors, especially with rucaparib, looking at potential drug interactions. Looking at the 2D6 pathway, they may very commonly be on antiemetics. On CYP1A2, I think we forget about caffeine, which a lot of us consume on a daily basis, may also lead to some toxicity issues. What is not as well recognized is the MATE1-2 transporter, and the proximal renal tubule facilitates the clearance of creatinine, and this is where in all the PARP studies we've seen elevations in creatinine, and not really well reported of the impact on creatinine clearance, which is drug clearance. Some common inhibitors of this pathway include the PARP inhibitors themselves, and this is a class effect. They're both substrates and inhibitors, and this is where we can lead into toxicities, especially with niraparib being longer half-life and more likely to accumulate. So be careful, monitor the patient's changes in renal function, and making those dose modifications proactively is important with the PARP inhibitors. Olaparib does have dosing guidelines, but both rucaparib and niraparib have not delineated renal dose modifications yet, but hopefully will in the near future. So when we look at the cost, kind of coming back to this, the take home here is that the PARP inhibitors have also shown not to be cost effective in the maintenance setting, which just leads us to a clinical dilemma of whether or not maintenance therapy has an overall clinical benefit, if that is a cost effective benefit as healthcare dollars become limited. So how to select? PARP inhibitors do need patients to be reliable and compliant because they're taking this oral agent at home. There may be limitations with insurance coverage or payment, and it definitely has shown more beneficial activity in those patients that remain platinum sensitive, so that did achieve that CR and are BRCA positive, but as the niraparib data show, there is some benefit for all comers. Bevacizumab are maybe better for those patients that have struggled with chemotherapy and have a lot of bone marrow suppression, low threshold for nausea and vomiting, may be better candidates for bevacizumab. So in therapy, in summary, the IP therapy really benefits on patient selection, and bevacizumab is now shown to be equally beneficial, so has kind of transitioned and replaced IP therapy. It's kind of fallen out of favor. But in gynecologic oncology, this all comes in waves, and the APC therapy may return in the near future, just as HIPEC or the intraperitoneal heated chemotherapy, which we didn't talk about today, is also coming into favor in the near future. Genetic testing should be a standard of care, and first-line maintenance definitely should be considered after complete or partial response, selecting either bevacizumab or a PARP inhibitor based on the patient criteria. So that is all I have today.